Now, as I told you, there are two ways by which cancer cervix can be prevented. One is by HPV vaccine, and everything about HPV vaccine just now I have told you. Second way is by screening. Now, there are three methods of screening which are available. Number one is HPV DNA testing. Number two is pap smear. Number three is visual inspection with acetic acid. I'm going to tell you a few important details about all these three methods, and then we are going to see how is screening for cancer cervix recommended by ACOG and by WHO. Again, I am telling you all this, what I am teaching is from the updated Williams, that is the Williams Gynae 4th edition, and it is from WHO guidelines. I'll share the WHO guidelines with you just now at the end of the session, and you can go through those guidelines. They are very, very important guidelines, right? Now, first talking about pap smear. Now, everything what I wanted you to know about pap smear, I have already told you. I told you that pap smear can be a conventional pap smear or it can be a liquid-based method. Pap smear is a specific method, but it is not sensitive. Now, the age at which pap smear screening with the help of pap smear should be started is more than equal to 21 years. So, at 21 years or beyond 21 years, if you are screening any female for cancer cervix, the method which you are going to use will be pap smear. Now, a very important point about pap smear is that based on the report of pap smear, treatment cannot be given, right? Whenever you get any report of pap smear which is positive, if it is positive, then you have to confirm it by colposcopy, and then only treatment has to be given. Based on pap smear report, I cannot treat a patient, right? Now, how often can you repeat pap smear? Pap smear can be repeated after every 3 years. Now, report of pap smear. Now, as I told you, pap smear is a cytological test which is going to detect squamous cell abnormalities and it is going to detect glandular cell abnormalities. Now, the squamous cell abnormalities can be in the form of ASCUS, LSIL, ASCH and HSIL, right? So, just write these and you'll understand. Now, if the report comes as ASCUS means atypical squamous cells of unknown significance. So, the cytologist is saying to you that I am seeing certain atypical squamous cells, but I do not know their significance. So, if pap smear report is coming as ASCUS, in that case, you have to see what is the age of the female. If age of the female is less than 25 years, you have to repeat pap smear, right? And this repeat you have to do it after 1 year, right? But if age of the female is more than equal to 25 years, then you are going to do HPV testing. You are going to see whether HPV is present or not. Now, whenever you do HPV after an abnormal pap smear report, so over here, the report was abnormal, the report was ASCUS, and now you are doing HPV testing. So whenever you are doing HPV after an abnormal pap smear report, it is called as reflex test. Don't worry, I'll make you write this when I'm going to do HPV with you, right? And if HPV DNA testing comes out to be positive, then you are going to go for colposcopy. So, if the report of pap smear comes as atypical squamous cells of unknown significance, you have to see the age of the patient. If age of the patient is less than 25 years, go for a repeat pap smear. If age is more than equal to 25 years, go for HPV DNA testing. And if HPV DNA is positive, then go for colposcopy. Right? Now, if report comes as LSIL, low squamous intraepithelial lesion. Now, whenever report comes as LSIL, again look at the age of the patient. If age of the patient is less than 25 years, what are you going to do? Again, you are going to repeat pap smear. right? HPV DNA testing is never done at less than 25 years, right? So if age is less than 25 years, I'm going to repeat a pap smear. Again, I'm going to repeat it between 6 months to 12 months. And if age is more than 25 years, I'm going to go for colposcopy. What is colposcopy? How it is done? Just now I'll tell you in a while. So as I told you, pap smear is only a screening method, and based on pap smear report, you are never going to do the treatment. And if you are getting a positive report of pap smear, in most of the cases, you are going to do colposcopy. This is not just colposcopy, this is colposcopic directed biopsy. But instead of writing this entire thing, colposcopic directed biopsy, in your options, either colpobiopsy would be written or simply colposcopy would be written. Even if they write simply colposcopy, it is but obvious that while you were doing colposcopy, you have taken a biopsy sample. Right? Okay. Then, now if report comes as ASCH, ASCH means atypical squamous cells where HSIL cannot be ruled out. So the pathologist is now saying to you that I am seeing certain atypical squamous cells and I cannot rule out HSIL. Right? Similarly, if you get the report as HSIL, so always I tell my students to remember that whenever this word H is there in the report, that means there are high chances for cancer. And when there are high chances for cancer at any age, the next step would be colposcopy. Right? And along with colposcopy, you have to do endocervical curettage. So you're going to understand a little bit more about colposcopy when I'll explain what is colposcopy. See, colposcope is a magnifying instrument. It's a big instrument which magnifies the cervix and it shows us a magnified view of the cervix, right? Now, the magnification of colposcope is 30 times and its focal length is 30. So what we do is, with the help of this colposcope, I'm going to look at the cervix and it is going to show me a magnified view of the cervix. Now, the problem with colposcope is that with the help of colposcope, you can see the exterior. That means you can see the exocervix. But what you cannot visualize is the endocervix. Endocervix cannot be visualized with the help of colposcopy. Now, whenever I have to do colposcopy, I am going to see whenever I get an abnormal pap smear report, I'm going to call my patient. So suppose if I'm getting a report of LSIL in a female more than 25 years, or whether I'm getting HSIL or ASCH, I'm going to call the female again to my OPD. And with the help of this colposcope, I have to look at the cervix and I have to take biopsy from various parts. That is what my aim is. Right? So first thing, before I take any biopsy, before I do colposcopy, first thing what I'm going to do is I am going to do a urine pregnancy test if that is indicated. Right? So you have to do a urine pregnancy test before colposcopy if it is indicated, if the female is telling you that yes, she may be pregnant. Then you also have to do a bimanual examination. This bimanual examination is done to see whether the cervix is enlarged or not, or if you are getting any signs of malignancy, like for example, if you are getting a firm cervix, or if you are getting any friable mass, or if you are getting a barrel-shaped cervix, then that means that you are dealing with malignancy, right? And if there is any intrauterine pathology, so yes, you have to do a bimanual examination. Now, after you've done a bimanual examination, you are going to use this colposcope, and with the help of this colposcope, you are going to take biopsy from any rough area. If you see any rough area on the cervix, the area which is not smooth, from there you are going to take biopsy. And you are going to take an biopsy from any area which appears white. Just now it is appearing white under naked eyes. right? So on naked eye, if any area is appearing white, then also you are going to take biopsy from that particular area. Any area which appears rough or any area which is appearing white just now, I have not applied anything. Without applying anything, if I'm getting any area which is appearing white, I'm going to take biopsy from that area. Then I am going to apply acetic acid. Now, when I'm going to apply acetic acid, right, 3 to 5% acetic acid, what is going to happen? Now, when you apply 3 to 5% acetic acid, the dysplastic cells, wherever dysplastic cells are present. Now, dysplastic cells have a very important characteristic, and I'm sure all of you know that, and I have also told you this in gynae patho integration, that in dysplastic cells, there is increased nuclear upon cytoplasmic ratio. Right? Now, when you apply acetic acid to dysplastic cells, the proteins which are present in the nucleus, they coagulate. So the proteins coagulate, right? There are a lot of nuclear proteins present, and these nuclear proteins coagulate and they start appearing white in color. Right? So whenever you apply acetic acid, dysplastic cells are going to appear white in color, and this is what is called as aceto-white appearance. Aceto-white appearance. So you are going to take biopsy from any area which appears white in color. See, when I did a pap smear, right, and I called the female for taking biopsy, I was seeing a very normal cervix. I didn't know from where to take biopsy. Now, when I did colposcopy, now I know that any area which is appearing rough, I should take biopsy from there. Then any area which is appearing white, prior to applying acetic acid, from that area I should take biopsy. Then I applied acetic acid. Now, when I applied acetic acid, the normal epithelium is going to appear pink in color. Only the area where malignant dysplastic cells are present, those areas are going to appear white in color. Now I exactly know, after applying acetic acid, that this is the area from where I have to take biopsy. These are called as aceto-white areas. So you have to take biopsy from aceto-white area. Aceto-white area means area which appears white after applying acetic acid. And the areas which appear white are those areas where dysplastic cells are present. When you apply acetic acid, please remember, when you apply acetic acid to normal epithelium, it appears pink in color. And when you apply acetic acid to metaplastic epithelium, it appears grey in color. Clear? The third thing, now in colposcope, there is a green filter, right? Green filter means there is a green light. So I am going to switch that green light on, and this green light, it helps to identify abnormal blood vessels. It helps to identify abnormal blood vessels. For example, punctate blood vessels, mosaic blood vessels, and reticular blood vessels. Clear? So I am also going to take biopsy from any area where abnormal blood vessels are present. Right? So if that is what is colposcopy. So when I said that if there is ASCH, or when there is HSIL, or when there is LSIL, and age of the female is more than 25 years, you have to take biopsy, and this biopsy is going to be taken with the help of colposcope. Right? Now, please remember, colposcopy cannot visualize endocervix. With the help of colposcope, you cannot visualize endocervix. That is the drawback of colposcope. So this means if I have to rule out lesions in endocervix, right, for lesions which are there on exocervix, I am relying on colposcopy and I am taking biopsy with the help of colposcopy. What about if there is a lesion which is present in endocervix? Now, for whenever you are having lesion in, whenever you are suspecting that a lesion may be present in endocervix, then you should do endocervical curettage. Endocervical curettage. So in all females in whom you are getting report as H, whether it is ASCH or whether it is HSIL, whenever this alphabet H is present, you have to do colposcopy so that you can rule out cancers which are present at the exocervix or CIN which is present at the exocervix. Plus, you should do endocervical curettage so that you can rule out cancers which are present in the endocervix or CIN or adenocarcinoma in situ. Clear to all of you? Yes. So now I'm going to take you back, bachon, to the report of pap smear. And as I told you, if report of pap smear is coming as ASCH or if you are getting the report as HSIL, you should go for colposcopy and endocervical curettage. Have you understood this? Yes. Now, as I told you, pap smear can detect squamous cell abnormalities as well as glandular cell abnormalities. Now, what are the glandular cell abnormalities which you can get? The glandular cell abnormality which you can get is atypical glandular cell of unknown significance. Right? Now, if you are getting a pap smear report as atypical glandular cells of unknown significance, that means you are getting columnar cells and you don't know their significance. Now, these columnar cells can come from endocervix or these columnar cells could have come from uterus, right? So, whenever you get a pap smear report as atypical glandular cells of unknown significance, then you should rule out cancer cervix, plus you should rule out endometrial cancer. In other words, what are the things which you are going to do if you get a report as atypical glandular cells of unknown significance? Number 1, you are going to do colposcopy. Number 2, you are going to do endocervical curettage. And number 3, you are going to do endometrial biopsy. All these 3 things should be done if you are getting a report as atypical glandular cells of unknown significance. Have you understood what are the different pap smear reports which you can get and how you are going to follow up? Now, if you've understood this much, you will also understand that, as I told you earlier, when you do pap smear, based on pap smear report, you cannot treat a patient. Right? And these days, WHO is advocating that in resource-limited countries, so this is what WHO is saying, that in resource-limited countries, there is a see and treat method. So that is what WHO is advocating, and that is what I'm going to tell you when I'm going to talk to you about screening for cancer cervix. So WHO is saying that in a resource-limited country like India, we are a resource-limited country, right? We are not a poor country, but we are resource-limited country. And in a resource-limited country, WHO says that you should see and treat at the same setting. Now, if you have to see and treat at the same setting, can you use pap smear as the primary screening method? No. Because whenever you do pap smear, it has to be followed by colposcopy, right? It has to be followed by a biopsy. Then only you are going to know whether CIN is present or not, right? So treatment cannot be done based on pap smear report, and that is why pap smear cannot be used as a primary screening test. So earlier, yes, Pap smear was being used as a primary screening test everywhere. But in resource-limited countries, WHO is saying see and treat, and that is why nowadays in resource-limited countries, Pap smear is not being used as a primary screening test, right? So that was about one screening test, and that is Pap smear. Coming to the second type of screening test. Second type of screening test is HPV DNA testing. Now, the age at which HPV DNA testing is recommended is generally more than equal to 30 years. So, HPV DNA testing should be done at or beyond 30 years. But earliest HPV can be done at more than equal to 25 years, and just now we saw that. Now, what do you understand by co-test? Co-test means when you are doing HPV plus Pap smear together. Then it is called as a co-test. What is a reflex test? Reflex test is if HPV DNA testing is being done after an abnormal Pap smear report. So if HPV DNA testing is being done after abnormal Pap smear report, that is called as a reflex test. And just now I told you that if Pap smear report is coming as ASCUS and if age of the female is more than 25 years, then you should follow it up with HPV DNA testing, and that HPV DNA testing will be called as reflex HPV DNA testing. Now, HPV DNA is a very sensitive test, right? Whereas Pap smear was a very specific test. Now, earlier, HPV DNA testing was a part of the screening test along with Pap smear. So, as a standalone test, we didn't use HPV DNA. Now, WHO is recommending HPV DNA test as a primary screening test, especially in resource-limited countries. Right? So in resource-limited countries, WHO is saying Pap smear is not a primary screening test. WHO is saying HPV DNA is a primary screening test because based on HPV DNA report, you can immediately treat a patient as well. Right? I'll come to that a little later. Now, as I told you, HPV DNA test nowadays is being used as a primary screening test for see and treat approach by WHO. So, WHO says that whenever in resource-limited countries, when you do HPV DNA testing and if HPV DNA testing comes out to be positive, now, who is going to take a sample for HPV DNA? HPV DNA sample can be taken by the provider or it can be a self-collected sample also. It has to be a cervical specimen. So in the cervical specimen, you are going to test for HPV DNA. Now, this is the advantage of liquid-based cytology. When you do a liquid-based cytology and after you have done cytology, study on it, in the same sample you can go for HPV DNA testing. Right? So you need a cervical specimen for HPV DNA testing, which can be collected by the provider or it can be self-collected. And if in that cervical specimen, HPV DNA test comes out to be positive, then WHO says that at the same setting, you can go for treatment. You don't need to do any other test. And that treatment could be either ablative treatment or it can be LEEP. I'm going to tell you more about ablation and LEEP in a little while. Over here, I just want you to write this. If HPV DNA test is positive, WHO says that you can immediately go for treatment. Now, HPV DNA test, if it is negative, then in that case, it has to be repeated after every 5 to 10 years in general population and after 3 to 5 years in a female who herself is either HIV positive or if she's living with an HIV positive partner. Right? So general population, it has to be repeated after every 5 to 10 years. If female herself is HIV positive or she's living with a partner who's HIV positive, then in every 3 to 5 years. Have you understood this? Okay. Now, if HPV DNA test is positive, what does that mean? If HPV DNA test is positive, it means that this particular female has infection from a high-risk HPV subtype. Right? So from a high-risk HPV subtype, infection is present, but what subtype, we don't know. So HPV DNA testing is simply going to tell you that yes, a high-risk HPV subtype is present in her. But if you want to know the exact subtype, right? In that case, you have to go for number one test. You can go for high risk HPV DNA test. This high risk HPV, this is not a simple HPV DNA test. It is high risk HPV DNA test. High risk HPV DNA test is going to test a female for HPV 16, 18, and sometimes it may test for 45 also. Right? This is a partial genotyping test. Then you can go for a COBAS test or on clarity test. These are three tests which tell you about the HPV subtypes, right? So normally the test which we do, the HPV DNA test, it doesn't tell you about subtype. It simply tells you that yes, some high risk HPV DNA is positive. Clear? Now that was the second test. One was pap smear as a screening test. Second one was HPV as a screening test. Now, third one is visual inspection with acetic acid, that is 3 to 5% acetic acid. Again, WHO is using this as a primary screening test for see and treat approach. So that means WHO is approving two tests as a primary screening test. One I told you is HPV DNA and number one VIA. So if I ask you, WHO is recommending which one? So if any one has to be chosen, then WHO says that HPV DNA is better than VIA as a primary screening test for see and treat approach. Although it is recommending both of them, you can use either HPV DNA as a primary screening test or you can use VIA as a primary screening test. But if both are available, then it recommends HPV DNA over VIA. Now, the principle of applying acetic 3 to 5% acetic acid is the same when I was talking to you about colposcopy. So, in VIA, you are going to apply 3 to 5% acetic acid to the cervical epithelium. Normal epithelium is going to appear pink, but dysplastic epithelium, it has got dysplastic cells, and dysplastic cells have increased nuclear upon cytoplasmic ratio, and these nuclear proteins are going to coagulate and they are going to appear white. That is, there will be an aceto-white area. Right, so this over here is how a test result of VIA is going to appear. So this is image A is normal cervix. When I have applied 3 to 5% acetic acid, you can see that some areas have become white, and this is where the dysplastic cells are present. Please remember, normal cervix is unstained by VIA, whereas the dysplastic cervix takes up the white stain. Right? Now, as I told you, if pap smear was being used as a screening test, pap smear had to be repeated after every 3 years. HPV DNA, if you are using it as a screening test, it has to be repeated after every 5 to 10 years in general population and 3 to 5 years in HIV, those females who are living with HIV partners. Now, if VIA is used as a screening test, then it should be repeated after every 3 years. Have you understood? Yes. Again, I am repeating, when you do VIA, the normal epithelium is unstained. It is the dysplastic epithelium which becomes stained. Why I am repeating this so many times is because one of the outdated tests is VILI, which is visual inspection with Lugol's iodine. Visual inspection with Lugol's iodine. Now, when you earlier what was happening was, instead of applying acetic acid, we were applying Lugol's iodine to the cervix. Now, when we apply Lugol's iodine to the cervix, the normal cervix, it has got sufficient glycogen stores, and when iodine is applied, they appear purple or brownish in color, purplish brown in color. The iodine is going to, the normal cells, because of increased glycogen, they are going to appear purplish brown in color, right? Whereas dysplastic epithelium, in dysplastic epithelium, the cells are actively multiplying or actively dividing. Now, because the cells are actively dividing, their entire glycogen is used up, right? And that is why they do not take any stain when you apply iodine. So when you are doing VILI, the unstained part is the dysplastic epithelium, whereas the stained part is the normal epithelium. This is exactly the reverse of aceto-white areas, right? VIA. In VIA, it is the stained area which is dysplastic and unstained is normal. In VILI, it is unstained which is dysplastic and stained one is normal. Have you understood this? Okay. So, these were the 3 screening methods. Now we are going to see the screening guidelines. Now the first screening guideline which I'm going to tell you will be ACOG recommendation, and this ACOG recommendation is for screening in resource-rich countries. And this is what the usual screening was which we have taught till now, that age to begin screening is 21 years according to ACOG, and irrespective of sexual activity, you should begin screening at 21 years, and the method which you are going to use will be pap smear. Pap smear should be repeated after every 3 years. So ACOG says that you have to do screening with pap smear initially. The primary screening test becomes pap smear. You have to repeat pap smear after every 3 years till a female reaches 30 years of age. From 30 years onwards, you are going to do co-testing, that is pap test, plus you are going to do HPV DNA testing. And you are going to repeat a co-test after every 5 years. When you were doing only pap smear, you were repeating it after every 3 years. And this you did up till 30 years of age. From 30 years onwards, you are going to do a co-test. And when you are doing co-test, you are going to repeat it after every 5 years. And you are going to do screening up till the age of 65 years if in the previous decade her screening was normal. Or you are going to take it up till 75 years if in the previous decade any screening came out to be abnormal. So the upper limit is 65 years if in the previous decade whatever screening was done was normal, or 75 years if in the previous decade the screening done was abnormal. Right? As I told you that as per pap smear report, further testing is done and then diagnostic test is done and then you go for treatment. Now, whenever you are doing a pap smear, based on pap smear report, you never do the treatment. After pap smear, whatever report comes, based on that report, we go for a diagnostic test and then we go for treatment. This is what is ACOG recommends in resource-rich countries, right? Now comes WHO's approach. WHO says that there are 2 approaches for screening of cancer cervix. One is a see and treat approach. See and treat approach is very good for resource-limited countries. Exact lines from WHO's guidelines PDF. So, exact lines are, in screen and treat approach, the decision to treat is based on a positive primary screening test only. So I'm going to do a screening test, and if that screening test comes out to be positive, I'm going to do treatment. Right? In screen, triage and treat approach, the decision to treat is based on a positive primary screening test, followed by a positive second test, which becomes a triage test, with or without histologically confirmed diagnosis. Right? So I'm going to do one test, which is a primary screening test. Then I'm going to do a second test. That becomes your triage test. And that is not necessary a biopsy, the second test. And based on both the positive results, I go for treatment. Right? That is WHO's screen, triage and treat approach. Right? The second is see, triage and treat approach. In see, triage and treat approach, you are going to do a screening test. If screening test comes out to be positive, you are going to do a secondary screening test, and this second screening test which you are doing is called as a triage test. Or you may go for a diagnostic test, and if they come out to be positive, you are going to go for treatment. Right? Now, yes, there are a number of algorithms which you will have to remember now. But before I start telling you about the WHO's screening guidelines, please remember that WHO says that the age to begin screening. In general population, the age to begin screening is 30 years. So in resource limited countries, WHO is saying that the age to begin screening is 30 years. ACOG says that the age to begin screening was 21 years. Right? WHO says you are going to begin screening by 30 years. In females who are living with HIV positive females, you are going to begin screening by 25 years. That is what WHO says. Now, according to WHO, the target population is 30 years to 49 years. And you are going to stop screening at 50 years if previous 2 screenings were normal. Whereas ACOG says you are going to stop screening at 65 years if previous decade the screening was normal. Right? Then WHO says that see, triage and treat approach is better than see and treat approach. Right? So if someone asks you that according to WHO, which is a better screening test, and in your options it is written as HPV DNA testing, VIA, HPV and VIA, and pap smear. So please remember that WHO is saying that see, triage and treat is better. That means 2 screening tests are better. One is a primary screening test and the second one is a triage test. So WHO says that HPV plus VIA is better than HPV and then VIA. So HPV plus VIA is better than HPV alone, and HPV alone is better than VIA alone. Clear to all of you? In this order, you have to remember that WHO is recommending that as a screening test, you should use HPV plus VIA. If that is not available, then HPV, and if HPV is not available, then VIA. Clear to all of you? Because it says that screen, triage and treat option is better than see and treat option. Clear? So what is the see and treat approach? As I told you, see and treat approach means that you have to do one screening test, and based on the result of that one screening test, you are going to do the treatment. Right? Now, the tests which are recommended by WHO for see and treat approach are 2 tests. Either you can do HPV DNA testing or you can do VIA. HPV DNA testing has to be repeated after every 5 to 10 years in general population, and in HIV positive population 3 to 5 years. VIA has to be repeated after every 3 years. Now, in the see and treat approach, WHO says that if HPV DNA testing comes out to be positive or if VIA comes out to be positive, then you have to give treatment, and that treatment is either ablation or LEAP. And once you've done treatment, after 1 year, you are going to follow it up again with HPV DNA testing. Right? So this entire thing you have to remember. That see and treat approach WHO is saying that you can, as a primary screening test, you can use HPV DNA testing or VIA. Which one will be better? HPV DNA testing will be better than VIA. Right? So either of the tests you can use, better is HPV DNA testing, and if they come out to be positive, either HPV DNA test comes out to be positive or VIA, and you are doing any one of them, then based on the report, you are going to go for treatment, either ablation or LEAP. And once treatment has been done, you are going to follow it up after 1 year with again a repeat HPV DNA testing. This is its see and treat approach. Now comes the see, triage and treat approach. Now, in see, triage and treat approach, it is saying the primary test could be pap smear or the primary test could be HPV DNA testing. And again, which one is preferred? HPV DNA testing. Right? So, I am going to tell you the entire details. Don't worry. Just keep copying. Now, in see, triage and treat approach, the primary screening test could be pap smear. Now, if pap smear comes out to be negative, then as I told you, pap smear has to be repeated after every 3 years. WHO says if pap smear comes out to be positive, right? Positive pap smear means the report is coming either as ASCUS or anything more than ASCUS. When I say anything more than ASCUS, it could be ASCH, it could be LSIL, it could be HSIL. So WHO says that if report is coming as ASCUS, then you are going to do triage with HPV DNA testing. Now you're going to say, ma'am, when we were doing pap smear, you said that if report comes as ASCUS and if female's age is less than 25 years, you go for a repeat pap smear. And if age is more than 25 years, you go for HPV DNA testing. Now you are saying that WHO is saying that if pap smear report comes as ASCUS, you go for HPV DNA testing. So, Arey Baba, what is WHO saying? WHO is saying that you have to start screening at 30 years. Right? So this means that ASCUS report you are getting at the age of 30 years or more than 30 years. And that is the same thing. I told you ASCUS at more than 25 years, you have to go for HPV DNA testing. Are you understanding? So WHO is not recommending pap smear below 30 years. It is not recommending screening before 30 years. So if report is coming as ASCUS on pap smear as per WHO's recommendation, then definitely it has to be followed by HPV DNA testing. And if HPV DNA testing comes out to be positive, then you have to go for colposcopy. If HPV DNA testing comes out to be negative, you continue with the screening. You do pap test after 3 years. Right? Now, if report comes as anything more than ASCUS, so I told you earlier also, if report comes as LSIL and more than 25 years of age, right? And over here we are doing screening at more than 30 years. So if report comes as LSIL more than 25 years, if report comes as ASCH, if report comes as HSIL, always it has to be followed by colposcopy, and if it comes out to be positive, you have to give treatment. So same thing WHO is also saying, right? So WHO is saying that see, triage and treat. You can use pap smear as a primary screening test. If pap smear report comes out to be normal, continue your normal screening. After every 3 years, do a pap test. If it comes out to as ASCUS, do a triage with HPV DNA testing. If report comes as anything more than ASCUS, then you are going to do the triage with colposcopy. Right? And if colposcopy comes out to be positive, then you are going to go for treatment. Is this clear to all of you? Yes. Now, better than pap smear is HPV DNA testing for see, triage and treat approach. Now, when you are doing primary, you are using HPV DNA testing as a primary test, and if HPV DNA testing comes out to be negative, then I told you in general population it has to be repeated after every 5 to 10 years, and in HIV females who are living with HIV positive partners, you have to repeat it in every 3 to 5 years. Now, if HPV DNA testing comes out to be positive, then WHO's we are doing see, triage and treat approach. So what are the triage tests which you can use if HPV DNA comes out to be positive? Now, if HPV DNA comes out to be positive, you can go for HPV genotyping. Right? As I told you, HPV DNA positive means that high risk are present, but which genotype is present, we don't know. Right? So I can go for HPV genotyping, number 1. Number 2, I can go for pap smear. Number 3, the triage test could be VIA. Number 4, the triage test could be colposcopy. So if HPV DNA test comes out to be positive, any of these can become the triage test, right? So I am going to tell you the algorithms with each one of them. I know this is a little difficult, bachcho, but you will have to understand this because questions are being asked on all new guidelines. And at the end of this PPT, at the end of this session, I'm going to show you the exact algorithms which WHO has published. right? I am making a little simplified for you, but then also I'm going to show you the exact algorithms so that you know that yes, this is what you have to study, right? Now, as I told you, if HPV DNA comes out to be positive, the triage test could be HPV genotyping. Right? So if triage test is HPV genotyping and HPV genotyping shows to me that HPV 16 or 18 is present, then immediately I'm going to go for treatment. Right? So HPV DNA came out to be positive. Then I did HPV genotyping, and when I did genotyping as a triage test, 16 and 18 HPV subtype was present, and because they were present, I took my patient for treatment. So C, triage and treat. Right? Now, if genotype is not, HPV 16 or HPV 18 are not present, but any other HPV is present. Now, if 16 and 18 is not present and any other HPV is present, then I am going to go for visual inspection with acetic acid. Then immediately I am not going to go for treatment. Then I am going to do a VIA. Is this clear to all of you? Now, suppose if HPV DNA was present and the triage test was VIA. Now, if triage test is VIA and when I applied acetic acid, I saw that aceto-white areas are present. So, positive means aceto-white areas are present. Aceto-white area is present. Right? So, if aceto-white area is present on applying acetic acid, I'm going to go for treatment. If aceto-white area is absent, now understand, HPV DNA is present, but aceto-white area is not present, right? Now I am worried that is this HPV infection going to persist? Because just now it has not undergone malignant transformation maybe. But if it is persisting, it may undergo malignant transformation. So instead of repeating HPV DNA after 5 to 10 years, as I told you, if HPV DNA comes out to be negative, you should repeat HPV after every 5 to 10 years. Now I am telling you a case where HPV DNA has come out to be positive. And you are doing triage test, and in triage you did VIA. When you did VIA, HPV DNA was positive but VIA is negative. In this case, I have to repeat HPV DNA, but now I am going to repeat HPV DNA after 2 years in general population and after 1 year in HIV patients. Right? Is this clear to you? Now, if HPV is still present, so HPV was initially present, VIA was negative. After 2 years, I repeated HPV and again HPV is present. Now that is going to ring an alarm, and that is the time when you should do colposcopy, because persistent HPV infection can lead to malignant transformation. Right? So now after 2 years, if HPV DNA is still present, then you should do colposcopy. I know it is a little difficult, but understand this. Are you understanding? Okay. Then, now comes, suppose the triage test which you are using is pap smear. So HPV DNA came out to be positive. And now I am doing pap smear. So here I am doing pap smear after HPV DNA test comes out to be positive. Right? So this is doing pap smear after an HPV DNA is positive. Now, if pap smear comes out to be negative, HPV DNA was positive, pap smear is negative. Again the same thing. I want to be sure that this HPV infection clears off. So I am going to again repeat HPV after 2 years in general population, after 1 year in HIV positive female, and if it is persisting, I'm going to go for colposcopy. Same thing, same series over here. And if on pap smear, I'm getting a report is positive. Positive means if I'm getting ASCUS or anything more than ASCUS, then I am going to go for colposcopy and treatment. If colposcopy comes out to be positive, treatment. Are you understanding this? Right? Now, the triage test after HPV could be directly colposcopy also. After a positive HPV DNA, you can directly go to colposcopy, and if colposcopy comes out to be positive, you can do treatment. So after a positive HPV, you can do either HPV genotyping, or you can do VIA, or you can do pap smear, or you can do colposcopy. And what is recommended by WHO is HPV plus VIA. So WHO says that for C, triage and treat, best is HPV and VIA. That is why I told you that C, triage and treat is better than C and treat, and that is why HPV plus VIA is a better test than HPV alone or VIA alone. Clear to all of you? Yes? Now, as I told you, normally if HPV DNA is negative, then it should be retested after 5 to 10 years as per WHO's guideline. But if HPV DNA is positive and the triage test is negative, that triage test could be VIA, that triage test could be pap smear. In that case, HPV should be repeated after 2 years in general population or after 1 year in HIV positive females. This is very, very important for you to remember. Now, everything about colposcopy I have told you. So, as I told you, colposcopy can visualize only the exocervix. Endocervix cannot be visualized by colposcopy. Right? Now, there was one term which I used and I told you that is endocervical curettage. So, I told you that if you are getting, if you are suspecting a lesion in endocervix, then because colposcopy cannot visualize lesions in endocervix, you have to go for endocervical curettage. So I want to tell you a little more details about endocervical curettage. What are the indications for endocervical curettage? See, number one indication for endocervical curettage is, which I told you just now, if you were doing pap smear, and pap smear report comes out to be HSIL, then you have to go for colposcopy plus endocervical curettage. If report comes as ASCH, then you have to go for colposcopy plus endocervical curettage. If report comes as atypical glandular cells of unknown significance, then I told you you have to do colposcopy plus endocervical curettage plus endometrial biopsy. Or if report comes as adenocarcinoma in situ. Right? The other two indications are if transformation zone is not fully visible. If you are unable to see transformation zone completely on colposcopy, right? Or suppose transformation zone is visible but no lesion is identified. Then in that case also you have to go for endocervical curettage. Please remember, endocervical curettage, it should not be done in a pregnant female. Endocervical curettage is done by taking an endocervical curate 1 to 2 centimeters deep into the cervical canal. Now, although we are saying endocervical curettage, either you can go for endocervical curettage or you can go for endocervical brushing. Both these come under endocervical sampling. So this is indications for endocervical sampling. In endocervical sampling, both these methods are there. You can do a curettage or you can do a brushing. So whether I say endocervical sampling, whether I say endocervical curettage, whether I say endocervical brushing, it's one and the same thing. And these are 3 indications for performing doing endocervical sampling. Right? Number 1, transformation zone not fully visible. Number 2, transformation zone is visible, but I cannot identify any lesion. Right? And number 3 is that if you are getting a report of ASCH, HSIL, atypical glandular cells of unknown significance, or adenocarcinoma in situ on pap smear. Clear to all of you? Then you have to go for endocervical curettage. Now suppose endocervical curettage report comes and the report says adenocarcinoma in situ. Now whenever you are getting a report as adenocarcinoma in situ, there are very high chances that there could be pre-existing invasive cancer. Right? So whenever you get a report as adenocarcinoma in situ, it is very, very important that you rule out that there is no cancer there, right? And you are going to rule out that there is no cancer there by doing a biopsy, special biopsy, which is called as cone biopsy. In cone biopsy, so suppose this over here is endocervix, vagina, and this is the exocervix. So in cone biopsy, you are going to take a cone-shaped area of the cervix and you are going to send it for biopsy. This cone is going to include endocervix. This cone should include transformation zone and it should include exocervix. So whenever on endocervical curettage, the report comes as adenocarcinoma in situ, before you say I'm going to do a hysterectomy, right? You have to rule out that there is no invasive carcinoma already present in the endocervix. And in order to rule out that there is no invasive cancer already present in endocervix, you will have to do a biopsy. And the name of that biopsy is cone biopsy or conization. And once you are sure that there is no invasive cancer, then you are going to go for hysterectomy, because if cancer is present, then I'm not going to do a simple hysterectomy, right? Then either I'm going to perform a radical hysterectomy or I'm going to do chemoradiation depending upon the stage of the cancer. So first be sure that there is no cancer and then go for hysterectomy. So remember, for adenocarcinoma in situ on endocervical curettage, if they ask you what is the next step is cone biopsy. If they ask you what is the best management of adenocarcinoma in situ, best management is hysterectomy. And this hysterectomy, definitely it is going to be done only if childbearing of the female is complete. Now, if female says, no, just now I want to complete my family, I cannot undergo a hysterectomy, in that case, you have to explain to her very carefully that in detail that there are high risk of cancer in you. It could be that there is cancer pre-existing in you, number 1. Number 2, you have to do a long-term surveillance in her, right? So you have to do a long-term surveillance. And number 3, as soon as she completes her childbearing, as soon as she completes her family, you are going to take her up for hysterectomy, because management of adenocarcinoma in situ is hysterectomy. Clear? Now coming to report of colposcopy. I have told you a report of endocervical curettage. Now let me discuss with you report of colposcopy. As I told you, colposcopy is a biopsy. And biopsy report is going to come as CIN1, CIN2 or CIN3. Right? Now CIN1. If you are getting report CIN1, I told you CIN1 histologically it is corresponding to LSIL or it corresponds to HPV changes. Now, it has a high rate of spontaneous regression. So, most of the CIN1s are going to regress, right? And mostly regression occurs in 2 years. So, whenever I get a patient in whom colposcopy report is showing me CIN1, then CIN1, it needs no treatment. You have to just follow it up for 2 years, because most of the cases are going to regress within 2 years. right? If CIN1 persists for more than 2 years, then treatment has to be done, and then the treatment is cryoablation. Cryoablation if the criteria are fulfilled. If the criteria for cryoablation is fulfilled, then the best management for CIN1 is cryoablation. If the criteria is not fulfilled, then you are going to go for LEAP. But the best management for CIN1 is cryoablation if the criteria are fulfilled. As far as CIN2 and CIN3 are concerned, you have both the options. You can go for cryoablation or you can go for excision procedures, excisional procedures like LEAP or LLETZ, or excision procedures like conization. Now, in case of CIN2 and CIN3, for any age and any parity, the best management is LEAP or LLETZ. For CIN1, the best management was cryoablation. I was preferring cryoablation over LEAP, right? But in CIN2 and CIN3, at any age and any parity, I am going to prefer LEAP or LLETZ. Both of them are the same procedures. LEAP stands for loop electro-excisional procedure, and LLETZ stands for large loop excision of transformation zone, right? Then, now, WHO says see and treat policy or see triage and treat policy, right? Now, WHO says, it is saying that colposcopy is not mandatory, right? WHO is saying that you can use primary test as HPV. If HPV comes out to be positive, treat. If a VIA comes out to be positive, treat, right? Now, report of HPV DNA testing, report of VIA is never going to come as CIN1, CIN2 or CIN3. Obviously, HPV DNA testing is only going to come out to be positive, and then WHO says treat and use either cryoablation or LEAP. So then WHO also tells you that in which cases you should use cryoablation and in which cases you should use LEAP. So according to WHO, the criteria for eligibility of ablative procedure is, number one, there shouldn't be any suspicion of invasive cancer or glandular disease. So you should not suspect any invasive cancer. Neither should you suspect a glandular disease like adenocarcinoma in situ or adenocarcinoma. Number two, transformation zone should be fully visible. The whole lesion is visible and it should not extend into endocervix. So, it is a type 1 transformation zone. You remember I told you type 1 transformation zone where the transformation zone is completely visible and it is not going into the endocervix. So WHO says that in see and treat approach or see triage and treat approach, when you are doing treatment and if you are not suspecting any invasive cancer, if you are not suspecting any adenocarcinoma in situ, if it is a type 1 transformation zone and the lesion, you did a VIA and the entire lesion was appearing on the exocervix, the lesion should not extend into the endocervix. In that case, you are going to go for ablation. If the criteria is not fulfilled, go for LEAP. Right? Why I'm telling you this is right, that if CIN1 is there, go for ablation. If CIN2 and CIN3 are there, go for LEAP. But what about the WHO approach? How am I going to decide? Because WHO's report is not based on colposcopy, right? So how am I going to decide when to do ablation, when to do LEAP? So that problem is solved by WHO by giving an eligibility criteria which says that if it is a type 1 transformation zone, if the entire lesion is visible on exocervix, nothing is going into the endocervix. and you are not suspecting invasive cancer, then go for ablation. If these criteria are not getting fulfilled, go for LEAP. Clear to all of you? Yes? So let's talk about cryoablation. As I told you that what is the criteria for doing cryoablation? The criteria for doing cryoablation is the one which WHO told. Along with that, some other criteria are endocervical curettage should be negative. Right? So if you have done endocervical curettage, it should be negative. And that is what WHO also said. Na? WHO, what was WHO saying? WHO was saying there shouldn't be any glandular disease. So how am I going to know that there is no glandular disease? If I did an endocervical curettage and endocervical curettage has come out to be negative. So now I'm going to tell you a little bit details about cryoablation and about LEAP. See, as I told you, the criteria for cryoablation is the same what WHO said. Now, so many times in your exams, they try to confuse you. So they are going to ask you, should cryoablation be done if endocervical curettage is positive or if endocervical curettage is negative? That is common sense. WHO is saying that you have to do cryoablation if there is no suspicion of invasive cancer and glandular disease. Glandular disease means a problem in the endocervix, right? Which means that endocervical curettage should be negative. Then only you will be able to do cryoablation. The other thing is, the WHO is saying that the entire lesion should be visible. Then only you can do cryoablation, which means that the lesion should be small. In other words, it should be limited to 2 quadrants of the cervix. Please remember, cryoablation is never done for treating CIN3. It was the treatment of choice for CIN1, but it is never done for treating CIN3. It is never done for treating CIN in a female who is HIV positive. And it is never done after any previous therapy. So if any previous therapy failed, right? For example, you did a LEEP, and after doing LEEP, it failed, right? Then you are not going to do cryoablation. So after any treatment which has failed, you are not going to do cryoablation. Is that clear to all of you? Yes? One very important thing which I am telling you, I told you that WHO has said that when you do treatment could be cryoablation, treatment could be LEAP, right? So that is what WHO said, that when you are doing treatment, if the criteria is fulfilled, then you go for cryoablation. If the criteria is not fulfilled, you go for LEAP or LLETZ. Now, WHO also said that after treatment, you have to follow up, and this follow-up has to be done after 12 months. And for follow-up, you are going to do HPV DNA testing, right? And suppose you did a follow-up and again HPV DNA testing comes out to be positive. Then again you are going to retreat. Now, when you are going to retreat, you are going to retreat only with LEAP or LLETZ. You never use cryoablation after a failed therapy. That failed therapy could be a previous failed cryoablation. That could be a previous failed LEAP. But you are never going to use cryoablation after any previous therapy, right? Is that clear? So CIN1's treatment is cryoablation. CIN3, you never use cryoablation. In females who are HIV positive, you never use cryoablation. And for after any previous therapy, you never use cryoablation. Now, what do you do in cryoablation? In cryo, I'm going to show you even a video of cryoablation where I'm going to show you that we use a cryoprobe, and with the help of that cryoprobe, we pass gases like carbon dioxide and nitrous oxide at very low temperatures. And when you pass carbon dioxide or nitrous oxide at very low temperatures, it leads to crystallization of intracellular water, and there is cryonecrosis. Now, when you are passing cold nitrous oxide, the temperature becomes as low as minus 65 degrees Celsius. Whereas cell death is going to happen at minus 20 degrees Celsius, right? Now, it is an OPD procedure, and in the video also I'm going to show you how the procedure is performed. You are going to press the cryo gun, and when you press the cryo gun, initially there is going to be a freeze. You are going to freeze it for 3 minutes. Then you are going to thaw for 5 minutes. Then again freeze for 3 minutes, and then again thaw for 5 minutes. So there has to be 2 sequential cycles of freeze and thaw. With the help of cryoprobe, the cervical epithelium is destroyed up till a depth of 7 millimeters. The adverse effect of cryoprobe is there will be persistent watery discharge. You are never going to get any bleeding with a cryo ablation. The disadvantage of cryoablation procedure is that you do not get any tissue sample for doing histopathological examination. When I'm going to do a LEEP, I'm going to tell you how a LEEP is done. You get a tissue which you send it for histopathological examination. After cryoablation, I'm not taking out any tissue, right? I'm not getting any tissue for histopathological examination. Right? Then comes LEEP or LLETZ. As I told you, LEEP stands for loop electroexcisional procedure. LLETZ stands for large loop excision of the transformation zone. So the name itself tells me that I am going to excise the transformation zone. Right? Again, this is an OPD procedure. No anesthesia is needed. You get small wires like this. You get small instruments which have got wires attached. Right? And through these wires, I'm going to pass a current, and this wire is going to cut and coagulate at the same time. So when I'm going to pass a current, it is going to cut the tissue, and then I am going to coagulate the bleeders. Right? So this is a short procedure which takes 10 minutes. No admission is needed. There is minimal bleeding, and tissue is removed up till a depth of 10 millimeters. And whatever tissue is removed, I'm going to send it for histopathological examination. Please remember that LEEP or LLETZ is the treatment of choice for CIN2 and CIN3 at any age and any parity. By just a 10 minutes procedure, you can treat CIN2 and CIN3 by just a 10 minutes procedure. And that is why, where is the need for doing hysterectomy? So hysterectomy is never done for treating CIN. Right? Hysterectomy is a major surgery. For CIN, we never do hysterectomy. Right? So suppose if they ask you that there is a female, and in that female, they can give you various types of combinations. They can say that there is a female who is 55 years old. Her family is complete. And you are getting CIN3 on colposcopy. What is the next step? Please remember that next step is LEEP or LLETZ. Right? That is question number 1. Question number 2 could be that you have a female in whom LEEP was done, and again this female has CIN. Now what is the treatment? Again you can go for LEEP. Right? LEEP can be done again. But if you are getting if you are getting a recurrent disease, you are doing LEEP and again CIN is there, you are doing LEEP and again CIN is there, then in that case you should go for hysterectomy. Once if recurrence is happening, you can go for LEEP. But if it is a recurring disease, every time you are doing LEEP and again CIN is happening, again you are doing LEEP, again CIN is happening, then that is an indication for hysterectomy. Other than that, there is no indication for hysterectomy. Right? Other than this, hysterectomy is never done to treat CIN. Is that clear? For any age group, for any parity, best management for CIN2 and CIN3 is LEEP or LLETZ. Right? Now coming to just one thing which we need to know a little more details, and that is cone biopsy or conization. As I told you, cone biopsy or conization means that you are cutting a cone-shaped cervix in such a manner that the sample includes endocervix, it includes exocervix, and it includes transformation zone, right? Now here, the advantage of conization or cone biopsy is that you are getting a sample from endocervix, and apart from this, it is also going to tell you about invasion, right? So it is going to tell you whether the problem has extended to endocervix or not. And along with that, you are getting a tissue sample. And because you are getting a tissue sample, you can comment upon the invasion as well. Whether it is adenocarcinoma in situ, whether it is, squamous cell carcinoma in situ, whether it is invasive cancer. Because if you get a tissue sample, you will be able to see whether the basement membrane is intact or not. Right? So you can tell about the invasion also, so much so that when I'm going to talk to you about cancer cervix, please remember that for diagnosing cancer cervix, pap smear is not a very good investigation, right? For diagnosing cancer cervix, you need to do biopsy, right? And that biopsy, the best way is cone biopsy, because in cone biopsy, you can comment not only upon squamous cell carcinoma, you can also come to know about adenocarcinoma, right? Then, the disadvantage of conization or cone biopsy is it is an OT procedure. It has to be done under anesthesia. Admission is needed. Obviously, if you are cutting a cone-shaped part of the cervix, you will have to do it in OT. You will have to do it under anesthesia. You will have to admit the patient, and it is a risk factor for preterm labor and cervical incompetence. Right? So what are the indications for doing cone biopsy or conization? One indication for doing cone biopsy was, I told you, if on endocervical curettage, the report is coming as adenocarcinoma in situ. If report comes as adenocarcinoma in situ, then my next step is to do a conization or a cone biopsy to rule out invasive cancer. Right? And the best management becomes hysterectomy. That was one. Number two, it means that anytime if I'm suspecting adenocarcinoma in situ, I should go for a cone biopsy or conization. Number three, anywhere where endocervical curettage is indicated, a cone biopsy can be done. Right? Because if endocervical curettage comes out to be positive, I have to do a cone biopsy. So all those indications which were indications for endocervical curettage automatically become indications for cone biopsy. For example, if transformation zone is not visible, if transformation zone is not visible, I cannot do a colposcopy. Right? For colposcopy, the entire transformation zone should be visible because a colposcopy cannot visualize endocervix. So if transformation zone is not visible, colposcopy cannot be done. Right? Similarly, if the lesion is extending onto endocervix, now if I'm seeing a lesion and that lesion is extending to endocervix, again I have to do a cone biopsy or an endocervical curettage. Or suppose your pap smear report, there is a female whose pap smear report is saying HSIL. Right? Now, as I told you, HSIL corresponds to CIN2 or CIN3. And when I did colposcopy report is coming out to be normal. Now, as I told you that a colposcope cannot visualize endocervix. So, if pap smear is saying HSIL is there and colposcopy is saying everything is normal, that means the problematic area is in the endocervix. This means my next step could be endocervical curettage or it could be a cone biopsy. Better is cone biopsy because if endocervical curettage comes out to be positive, again I have to do a cone biopsy, right? Now, these are the diagnostic indications for cone biopsy. Now, in cone biopsy or conization, whether I say conization, whether I say cone biopsy, it's one and the same thing. Because I am cutting a cone-shaped area of the cervix, so it can also be therapeutic. And the therapeutic indication for conization or cone biopsy is to treat stage 1A1 of cancer cervix. We will do cancer cervix just now. So to treat stage 1A1 of cancer cervix in young female, right? So that is the therapeutic indication for cone biopsy. Now just one quick question. I am saying that there is a transformation zone type 1 or a transformation zone type 2 and a pap smear was done. Now a diagnostic procedure has to be done. After pap smear, a diagnostic procedure has to be done and it is transformation zone type 1 or type 2. What is the diagnostic procedure? What do you think should be done? As I told you, after pap smear, you have to do a biopsy. The diagnostic procedure always is a biopsy. And if you are getting transformation zone type 1 or type 2, that means the entire transformation zone is visible. Right? So these are the ways in which they can ask you questions, bacho. So then I am going to follow it up with colposcopy. Right? But suppose they say that a diagnostic procedure, pap smear was done and the report is positive and a diagnostic procedure is needed, but transformation zone is type 3. Transformation zone type 3 means it is not visible on it is not completely visible. Now, if a transformation zone is not completely visible and they are asking you diagnostic procedure, what do you think it is going to be? It is going to be a cone biopsy or conization. So this is all what I wanted to tell you in CIN. Just the last thing which I want to show you is the WHO guidelines from where I have taken this entire lecture. This is a PDF. This PDF is available on Google. You can search for it. Over here, these are the various algorithms which WHO has said. Like over here, this is primary VIA screening, screen and treat approach. Then this algorithm is for HPV DNA testing, the screen and treat approach. Then this is algorithm for screen, triage and treat approach. So all these algorithms which I have taught you, they are there in this PDF which is freely available on Google. So you can just go and type WHO guidelines for screening and treating of cancer cervix. Right? Just type this. You will get all the information what I have told you in this video. You can verify from there. And once it is verified by you, once you feel confident enough, just learn whatever I have told you in this video. I know this is a little difficult, but then you will have to remember all these algorithms because questions are being asked on these algorithms. Hi students, now I'm going to show you how cryoablation is performed. For cryoablation, we have special cryo guns which are attached to cylinders. These cylinders, they have got compressed gases, nitrous oxide or carbon dioxide. And when you are going to release the cryo gun, then cryo gun is going to release these gases which are, under very low temperatures. So once these gases are released, they are going to bring down the temperature of the cervix to minus 20 degrees Celsius. And because the temperature is reduced to minus 20 degrees Celsius, the intracellular water is going to freeze and that brings about cryonecrosis. The only problem with cryoablation is that there is no tissue which we can send for histopathological examination, and cryoablation, it can destruct the tissue up till 5 millimeters depth. So look over here. Now, in this video, once you've adequately exposed the cervix and you can see the external os clearly. Now, cervix, the anterior lip of the cervix has been held by valcellum and we can clearly see the external os, and now you can see the cryo gun being applied to the area of transformation zone. Can you see over here ice formation being done? Right? So once the cryo gun is triggered, it is going to release the gases at very low temperatures, and can you see beautifully this ice formation is happening? This is what is cryonecrosis. Because the temperature has been lowered down, cryonecrosis is going to happen. This is how the external os area and the transformation zone is going to look like after you have done cryoablation. As I told you, the disadvantage is that there is no tissue available for histopathological examination. Be very careful before you trigger the cryo gun that normal vaginal epithelium, it doesn't come into the cryo gun, because whatever comes near the cryo gun, that entire area will undergo cryonecrosis. Hey all of you, now I'm going to show how LLETZ is performed. As I told you, LLETZ, that is the large loop excision of transformation zone, which is also called as LEAP, loop electroexcisional procedure. It's an OPD procedure and it hardly takes 10 minutes to do this procedure. Now this procedure is done under paracervical block. You are going at various places on the cervix. You are going to infiltrate the local anesthesia. Keeping in mind that you do not do it at 3 o'clock and 9 o'clock position, because that is where the descending cervical artery is present and I do not want any bleeding. Now I am going to select an appropriately sized loop, and this loop is like a pencil. So like you have a pencil, this loop is exactly like a pencil, which has got a wire at its proximal end and it also has got a press button. The moment you press that press button, then the current passes. So let's see how the procedure is done. Now, what you are seeing over here is this loop-like structure, right? So this is the electrical loop which I was talking about. So with the help of this loop, we are going to cut the transformation zone. You are going to begin your dissection from the 3 o'clock position and you're going to take it up till midway. And once you've done from 3 o'clock to midway, then now go from 9 o'clock and bring it up till midway. This ensures that yes, the entire transformation zone has been removed. So look again. See how easily and how quickly it is cutting the transformation zone. So we've taken it up till midway. Now back from 9 o'clock position, we are going to bring it up till midway. Now here the entire transformation zone has been removed. Now what you're going to do? Now you are going to change the tip. Now you are going to change it to a roller ball cautery, and whatever bleeders are present there, with the help of diathermy, that means with the help of this heat which the cautery is going to release, you are going to stop those bleeders, right? So the bleeders are going to be cauterized and the tissue is going to shrink. Because the tissue is going to shrink under the effect of heat, the bleeding is going to stop. So look over here. All the bleeders which are there, we are immediately going to cauterize them with the help of this roller ball cautery tip now. Right? And you can see that the procedure was over. The patient did not have any bleeding. Whatever tissue you had collected, the entire transformation zone, it is sent for histopathological examination. And that is the biggest advantage of excisional procedures like LLETZ or LEAP over cryoablation. I've also shown you the procedure of cryoablation. In cryoablation, no tissue was available. Over here, we have tissue available for histopathological examination. Hardly it took 10 minutes to perform this procedure, and so undoubtedly this is the management of choice for CIN2 and CIN3 in any age group. As gynecologists also, we don't need any special training to do this procedure, right? This is a routine OPD procedure and so easily the CIN can be managed, and that is why whenever you are going to get a question on management of CIN2 or CIN3 in any age group, in any parity, you are never going to say that we are going to do hysterectomy. One last question before I end this session. Up till how much depth can LEEP cut the tissue? I have told you this in the video. If you don't remember, go back, check, and then end this video. Take care. Bye-bye.